Acromegaly is a syndrome of excessive secretion of growth hormone after the growth plates have closed. It is an insidious, chronic debilitating disease associated with bony and soft tissue overgrowth and increased mortality. When it occurs in children, it's referred to as gigantism. So what causes acromegaly? It is usually caused by a pituitary adenoma, usually a macroadenoma in 75% of cases that produce growth hormone. Rarely, ectopic tumors can produce growth hormone-releasing hormone and cause this syndrome. Less than 1% of them happen to be malignant. Growth hormone excess manifests clinically as headaches and visual field defects, facial changes such as enlarged nose and mandible, cardiovascular problems such as hypertension, arrhythmias, hypertrophic cardiomyopathy, and accelerated atherosclerosis. Metabolic changes, including impaired glucose tolerance and diabetes, are also seen. Since there is a co-secretion of prolactin by growth hormone-producing tumors, menstrual problems are also common. There is an increase in shoe and glove size due to enlarged feet and hands. Patients with acromegaly also frequently present with obstructive sleep apnea, enlarged internal organs such as the liver, spleen, kidney, and heart, as well as musculoskeletal problems such as proliferated articular cartilage and osteoarthritis. Entrapment neuropathy such as carpal tunnel syndrome may also occur. Patients with acromegaly have symptoms for approximately 9 years before the diagnosis is made. The best initial and most sensitive lab test is blood insulin-like growth factor 1 levels, which are significantly elevated in acromegaly. The confirmatory and most specific test is growth hormone measurement after 100 grams of glucose is given orally. If growth hormone remains high, that is more than 5 nanograms per milliliters, the test is positive and is suggestive of acromegaly. Radiologic studies such as CT and MRI are used to localize the tumor but should only be done after growth hormone excess is documented biochemically. So how do we treat a case of acromegaly? The primary treatment is transsphenoidal surgery, which provides a rapid response. Hypopituitarism can occur in 10 to 20% of these cases. Somatostatin analogs are the drugs of choice for acromegaly. Octreotide and lanreotide reduce growth hormone values and cause partial tumor regression. The main side effect of concern with somatostatin analogs is cholestasis, leading to cholecystitis. Pegvisomant, which is used as a second-line agent, is a growth hormone analog which antagonizes endogenic growth hormone by blocking peripheral growth hormone binding to its receptors in the liver. Radiotherapy is used only if surgery and drug therapy do not work. Acromegaly can cause a number of complications. The most common cause of death in acromegaly is cardiovascular mortality. Patients can also develop type 2 diabetes, impaired lipid metabolism, sleep apnea, visual field defects, vision loss, cranial nerve palsies, bone overgrowth, arthropathy, and vertebral fractures.